this is the scene size up. In this part of the video, you can see that the BLS crew enters and they first assess the scene for safety. They're looking around for any kind of hazards that could negatively affect them. They're going to don their appropriate PPE if it hasn't already been placed. In this video, you'll see that the providers aren't wearing any kind of face mask or covering, and that is solely for the purpose of the video so that you can hear and see what the providers are saying. Standard PPE for BLS providers at this time is going to be a face mask, N95, surgical mask, gloves, and then additional PPE they can consider would be safety glasses, a gown, a hairnet, and booties. After that, we look around for how many patients we have. We see one person sitting in the room, so we know that our number of patients is 1. We decide, is this a mechanism of injury or a nature of illness? So seeing no obvious signs of injury from our initial impression, we determine that it's a nature of illness. And at that point, we don't think we need to take any C-spine precautions. The need for additional resources is an ever-evolving need. When we first walk in the door, we're looking at immediate obvious life threats that would indicate we need ALS, scene hazards, or the need for additional fire resources for hands, the need for a bariatric unit if we walk in and see that the patient appears to exceed 350 pounds or a size that would reasonably fit on our stretcher. Seeing no need for additional resources at this time, we proceed forward with the interview. However, we can always call for resources as the need becomes evident.
I did, thank you.
Okay. My name's Dina. This is my partner Jim. We're here from Gloucester County EMS. What's going on?
I'm really having some bad abdominal pain.
Bad abdominal. You'll notice that the primary assessment looks a lot like asking about the chief complaint. In asking the patient about the chief complaint, having them respond to me and talk tells me that their airway is patent. While they're talking, I can assess and see that they are breathing and that their breathing is adequate, even if I'm not stopping to do a full count. Their circulation refers to, do they have a pulse? Which if they're talking, I know that they do, as well as their general skin condition. And you'll see my partner will assess for a pulse almost immediately upon making contact. Disability, do I see any obvious reasons that this patient is having an ABC threat? Or is there anything interfering with my ability to do an assessment? Exposure. Neither of those things are present. I walk right up to my patient and I can easily get to her. There's nothing stopping me from being able to move forward with my assessment. My level of consciousness is also assessed in this question because the patient immediately responds to me. The patient didn't need to be stimulated via verbal or painful stimulation. From there, I move on to making my general impression. Is this patient very sick? Or do I have time to figure out what's going on? In this scenario that you're watching, you'll see that the patient is what we call little sick, meaning there's definitely something going on, but I have time to gather a full history, get a full set of vitals. There's no immediate interventions that I need to take. I'm getting the chief complaint, again, by asking what's going on, and then I'm making a transport decision. At this time, with no immediate threats, no scene safety concerns, and determining that the patient is little sick, I'm going to make the decision to stay and play, which means I'm going to do a full assessment. And if there becomes a need to transport immediately, I can change that decision, but right now there's no rush to get out the door.
Ma'am, I'm going to check your vital signs while Dana asks you some questions.
Our baseline vitals should be obtained by the secondary caregiver. They can start obtaining vitals while the primary caregiver continues to ask questions related to the patient's history and their chief complaint. Now that we've gathered the basic information and determined that we're going to stay on scene and assess this patient, my partner will begin getting the baseline vitals while I ask questions where it's appropriate to talk. I don't want to talk to my patient while my partner's assessing a blood pressure or lung sounds because the patient will be responding, which will interfere with that assessment. But I don't need to wait until all baseline vitals are obtained before I move into my history taking. So did it come on suddenly or how did it start?
It started last night. I went to the new pizza place down the street.
Yeah.
And so when last night I got up in the middle of the night, my stomach just didn't feel good.
98, strong and regular. She feels a little diaphoretic.
Does anything make it feel any better or worse?
Nothing, that's why I called.
Obtaining a history, specifically the OPQRST, should flow like a conversation, meaning we need to be able to react to the answers that our patients give us, but bring ourselves back on track to make sure all of our answers are given. When we're obtaining our OPQRST, we shouldn't ignore any concerning things that our patient says just because it doesn't fall in line with our next question. So it's okay to elaborate on an answer that they give, but again, come back to where you need to be when you're done. You'll hear me repeat the time because the patient already told me what time all this started, but to ensure I'm doing a thorough assessment, I say it again to ensure I got the right information. After that OPQRST, we'll move into our sample history. The sample history could be done in the back of the ambulance. There's no need to delay transport to gather a sample history, but in a situation where we are still obtaining vitals or still gathering other necessary resources, we move right into our sample history. Do you have any other symptoms? Is anything else bothering you? SPN, or Associated Symptoms and Pertinent Negatives, means we're going to confirm if the patient has any symptoms that we believe would be associated with their chief complaint, even if they haven't already presented that information to us. Sometimes people are distracted by whatever the biggest problem is, so they don't think about other things that are going on. Pertinent negatives are things that we want to make sure the patient doesn't also have. So for example, this patient is complaining of cramping in the stomach. In women, sometimes stomach pain is actually indicative of a cardiac problem. So knowing that the patient does or does not have chest pain could either be an associated symptom or a pertinent negative for us.
As well. It sounds like she might be dehydrated.
Absolutely. 98%. And her skin appears to be tenting.
Okay. So we'd like to take you up to the hospital. Do you have a hospital preference?
Well, I like to go to Inspira.
In Spirit? Okay. We can take you there. My partner Jim is just going to go outside and get the stretcher. We'll bring that in, get you on it. While he's doing so, I have a couple more questions I'd like to ask you.
Okay, great.
All right. So we said no chest pain.
So the secondary assessment is a run through of all the body systems that we haven't yet assessed to see if there's any other involvement or other issues going on. It can play an important role in coming up with a differential diagnosis in a patient who has a vague complaint. When it comes to your secondary assessment, it's okay to go back and repeat things that the patient has already said to keep yourself on track and verify that you understood the information correctly. So saying things like, I believe you said, or you already said, show the patient that you were listening when they said it before and that you're just double checking for a complete understanding. The patient reassessment is important. Our patients should be reassessed after any kind of intervention, after any kind of movement or change in patient condition, as well as every 5 minutes in our unstable patients and 10 minutes in our stable patients. When we have a shorter transport time, meaning we're not with the patient to reassess more than one time, at an absolute bare minimum, we should assess them before we transfer care. Meaning that if we start transport with a blood pressure being checked, we transport about 8 minutes away for a stable patient, and then we're at the hospital, even though it hasn't been 10 minutes, we should check that pressure again before leaving the ambulance and going into the hospital. This allows us to trend vital signs or changes in our patient and also allows protection as BLS providers to ensure that when we transfer care, we are confidently giving a report about the patient's current status and not what it may have been several minutes ago.